So some of the racial disparities that have existed for women of color especially have been housing or lack of stable housing. So some of the women that we have worked with come from low-income communities, and so then seeking HIV care or staying in care becomes not high on the priority list when they have to worry about where they're going to live. Some of them living in a low-income community, then that means sometimes they live in a food desert. So then access to good food is also a big issue. So that affects their day-to-day lives and if they take the medication or not. And so that's how they end up falling off the care continuum. Another thing is transportation. We've had women who have to take 2 or 3 buses to get to clinic, or if they have competing priorities like low-income jobs and they have to work more than one job. So then making time to go to a medical appointment becomes a challenge. So some of these challenges have become more apparent to us, and so when we're trying to address these disparities, we have to collect all the information on housing and transportation, whether they have social support or a social network, because that also impacts how they fare in their treatment and their accessing care. We've had a group of women who also come from Africa, and they have a different set of challenges with disparities. So having language barriers, not knowing how to navigate the US medical system, changing medication from what they were getting back home to what is now in America, that also plays a role in disparities. And so when we're talking about HIV disparities, it's important to sort of have a deeper understanding of the root or upstream causes of why these disparities exist and how to better systematically address them instead of just looking at the clinical aspect.
That implementation was women of color who've been out of care for over 6 months, newly diagnosed, and what it was that clients who were newly diagnosed, we tried to get them into care. You had to see a case manager. You had to at least get 2 doctor visits. Try to help them with as far as getting housing and stuff later on. We tried to make sure that the clients, no matter what, got their medical appointments, seen a doctor. If they had any mental or any kind of drug abuse, we sent them to some of our offices to meet with our physical therapy people and different things that they really needed help with. For example, for newly diagnosed clients, just being scared, especially going to a new doctor and finding out the doctor is just like a doctor, but somebody that's not like them dealing with HIV, and to have that person that's been living with HIV to be able to help them and talk with them and show them that it's not the end of the world. Here, I've had HIV for 19 years, and look at me. I can't say that the same thing will happen with you, but to let you know that there is somebody that loves them and cares for them.
In addition to the peer navigation part, we also administered baseline interview and follow-up interviews. And so part of the interviews was also collecting the data on the social support networks, the barriers to care. And when we followed up with them at 3 months and 6 months, then we were able to see if some of these barriers had been addressed or if they were still an issue. And so that information also helps guide our clinicians on how to best treat the whole person.